Hi, everyone. Thanks for joining us. I'm Luann from Let's Grow Kids, and we're very happy to have you join us this afternoon for our fall, now seasonal conversation that we hold between early childhood education professionals and our Vermont children's health experts. Just to remind us, the goal of these conversations is to provide support for healthy young children in childcare and at home by sharing accurate information. And I'm going to quickly hand this over to Katie to get us started along with our experts and let them introduce themselves. But before I do, just want to give you some quick housekeeping details. We're recording and we will share the slides and the recording of this so you can let your colleagues know who aren't able to make it today that this is available. We have received questions ahead of time. Thank you for submitting questions as you registered, and we can take questions during the session through Q&A, so feel free to put them right into the Q&A box. And we are all muted, and that way the sound quality is as best as we can make it. And I just wanted, before we dive in, I wanted to mention that Brenda, who's done a great job facilitating these conversations for the last couple of years, has moved on to her new role, preparing with her new Vermont AUIC colleagues for the launch of the Sparks system. And so you all will most likely be hearing from her again very soon. And we're very excited about the launch of the new quality support system called Sparks through Vermont AUIC. So on that note, I want to hand it over to Katie and let us get started.
Hello, everyone. I'm Katie Leffel. I'm a nurse at the Department of Health in the Family and Child Health Division. And my colleague, Molly McClintock, who had joined me for previous Q&As, has moved on to a school nurse position in Essex. So we're going to miss her today. And it's just going to be me and my Vermont Department of Health colleagues and our pediatricians today. So I just wanted to quickly run over the agenda so you guys all have an agenda, and then just have a couple quick remarks. So we are going to have Brina and Becca talk. I'll let them introduce themselves, but we're going to have them have a little talk, pediatric talk from the pediatricians. We have John from our epidemiology team who's going to give a presentation. And then we have Meredith from our immunization team. Then we're going to go over the Q&A questions, the pre-submitted questions, and whatever was put in the chat too. So we'll try to get through all those questions, and then anything we can't answer, we will follow up with afterwards. And then we'll have our closing remarks. So I just wanted to take a pause and, as always, thank you for all that you do, and acknowledge that not this summer has been as hard as any of the summers in the last few years. COVID felt a little bit of relief, but we had flooding and we had air quality, and now we have heat, and it's just been a really, really rough summer, I think, for all Vermonters, and just especially important for all that you do to protect the health and the mental health and support the families in your care. So you're taking care of yourselves, you're taking care of your staff, and you're taking care of all of your families. And that's just so important. And so I just want to say thank you for that. And I will, when we send out the resources afterwards, I have just collected some of the resources around some of the heat resources, the flooding resources, the air quality, sort of just to kind of keep it all in one place for you all. So we'll include those in the resources when we send them out afterwards. I'm going to turn it over to Becca and Brina.
I was going to let Becca go first, but she's not unmuted. Or maybe she's on the phone. I think she's phone. Hi, everyone. I just felt a lot of emotion when Katie was talking. I could hear emotion in her voice, and I have that same set of gratitude remarks to share with you as you all assemble today, and we see Luann and her team, Araya, and then all of your names. Some of you are on camera. I just I don't think we talk enough about what we've all been through and what our collective experience is, and here we are kicking off another year, and your questions that have come in ahead of time are similar with a little bit of difference, but it feels like we're in an ongoing space of needing to collaborate and communicate very effectively and clearly, because you're not really doing this alone, but I'm sure some days it feels that way. And I just wanted to acknowledge that piece. And for those, if there's anyone new out there, I'm Brina Holmes. I'm a pediatrician, and I spent a long time at the health department, but I'm now at something called the Vermont Child Health Improvement Program, where we work on quality improvement, and we're very interested in health and safety and childcare with our colleagues at the health department. So turn it to Becca. If she's unmuted, maybe that's today's theme.
Yeah. Yep.
Okay.
Hi, everyone. So I'm Becca Bell. I'm a pediatric intensivist, and I work at UVM Children's Hospital in Burlington. And I do also want to echo what everyone's been saying, just so much gratitude. And I think my role here is to really help with setting some expectations heading into the fall. So Katie listed a bunch of things that have happened during the summer that have been challenges. And I think when we don't know what to expect, things can seem really overwhelming in terms of, and what I'm really thinking about are respiratory viruses. So that's kind of what I want to talk about today, and I'm here for. I think every year we always forget how bad the fall and winter are in terms of respiratory viruses. And I can share the experience at what we're seeing in the hospital, which is nothing right now, but what we see every year and what we expect to see upcoming. And I'm so happy to see Meredith here, because I also have some light at the end of the tunnel that, in terms of some RSV prevention, that we might be able to get going this season and certainly in future seasons. And I see you all as like a huge resource for families in talking about both an upcoming vaccine for pregnant people for RSV to help protect their babies when they're born, and then also this RSV shot that we can give to babies that we're hopefully going to start being able to do soon. And RSV is a thing that just gets children that you take care of so sick. So I think it would be great. We don't have all the information. Just want to set expectations. We don't have a lot of practical information about that today, but just to let you know that that's coming. And I think in the future that can really make a difference for these respiratory viral seasons. So I'll stop there, but I think a lot of the questions coming up are going to sort of incorporate a lot of this like fall, winter type season and what we expect. Last year was tough, and every year is tough. So we just want to get ready for that.
Thank you guys so much. I'm sure there'll be questions coming up, but like Becca said, lots of questions pre-submitted that will have lots of good topics. And so next we're going to turn it over to John.
Hey, thanks, Katie. And thanks everyone again. Just want to reiterate what a privilege it is really to be able to meet with you guys who serve our kids and families so well and look out for us all so well. I know probably a lot of folks had hoped that they wouldn't be hearing from a COVID coordinator at this point in time, but we, as we are sort of moving away from COVID being job 1, 2, and 3, COVID is obviously still with us, still impacting a lot of people's lives. So based particularly on some of the questions that were coming in, I think it was felt that it would be helpful for us to come and present, give a sense of where we are right now, how we see things going, kind of get us all set up going into the year for how we should be thinking about COVID. Should I be sharing my screen oh, thank you. Okay. So I just want to give a little overview. The next slide, just kind of what I'll be going over. We're going to talk about what has and hasn't changed since last winter, kind of thinking about things on the school year season, respiratory disease season model. Going to just give a quick overview of the current COVID-19 and a little bit of the other respiratory illness picture guidance as we go into this kind of forthcoming season. And then I know we'll be taking questions later too. So we go on to the next slide. So as folks might recall, with the ending of the federal emergency last year, those COVID community levels that some folks here probably paid a lot of attention to, the high, medium, low COVID that sort of guided certain COVID mitigation and protection responses was replaced with hospitalization levels, which just looked at the metric of new hospitalizations of individuals with confirmed COVID-19. That was actually a really useful metric. It really kind of was the driver of any change in level that we saw in Vermont. There's still a lot of robust data collection. There's still a lot of tests going on in hospitals, and a lot of good reporting. So operationally, that really only impacted the healthcare and nursing industry when that went away, but it is a different change in terms of what we're steering folks to look at if they want to look at an indicator of COVID-19 activity. It's helpful because it's not just folks showing up at the hospital for COVID, but it's everyone who has COVID that shows up. So it's a really good indicator, because even if folks aren't coming in for COVID-19 as their major symptom that brings them to the hospital, if they have COVID-19, if we see a large increase in this, we can feel confident there are increases at the community level, in addition to our other indicators that we monitor. Along with the changes, laboratories and providers are no longer required to report negative COVID-19 tests in Vermont. Again, not a direct impact on a lot of folks here, but a lot of our labs, healthcare facilities, were happy to hear about that. We continue, COVID is still with us and vaccines are still with us, and we continue to see population kind of increase its immunity based on immunization and an infection. And I don't want to step on anyone else's presentation, but we're kind of moving, we heard a lot of talk about being up to date with vaccinations, being vaccinated, being this, being that. We're kind of shifting towards an annual recommended vaccine for COVID-19 that'll go with flu and maybe in the years coming with RSV as well. So go on to the next slide, talk about what hasn't changed. The basic recommendations for infection control and prevention haven't changed. We hear a lot when there are new variants that come out. It's really exciting science. But none of the recent variants have presented any need to change anything. It really doesn't change the game. It's still the same COVID-19 that we can, mitigate and reduce the risk of with masking, with good air quality, with vaccination. And like our previous respiratory disease season, which was really the first year we saw this, COVID-19 coexisting with other similarly presenting diseases. And that coexistence kind of offers some challenges and also kind of some opportunities here. So we can go on to the next slide. There was a lot of attention in a recent increase that we saw in COVID-19 activity in Vermont and elsewhere in the United States. We actually saw a little bit earlier in Vermont in the summer. But this has really, that and this most recent increase has really been coming off, if you look at this chart of the hospitalization indicator, really coming off of the sustained lowest period that we've seen since the Delta wave first hit. So, and we have seen that increase possibly level off a bit. Now, as we know, college kids, schools are back, so we may see that tick up, but we're starting in a better place than we've been at this time of year in years before. So I want, don't want to give folks a false sense of security, but we truly are at a better place, not only in terms of vaccines, treatment, the immunity in the population, but really in terms of the COVID activity level. We're starting the school year in a better place than we had. Next slide. We recently did see, and I believe Dr. Bell's going to talk about this, but recent sort of increase in RSV in, I believe, Florida and Georgia or somewhere else in the southeastern United States. Historically, this has kind of suggested that we would start to see RSV season really picking up over the next 2 or 3 months. I think the expectation is that may be the case this year. So something to keep in mind as we continue this conversation today, that we may start to see this increase in RSV really in just a couple of months. And the next slide. So flu activity currently minimal, but it may again be higher this year, like we saw last year, an increase. We saw that kind of early bump. We were kind of bracing ourselves for a later one that fortunately we didn't get didn't get slammed too bad late in the flu season. Starting October 13th, Vermont's weekly flu surveillance reports will be available on our webpage. So you can come to the Vermont Health Department webpage to get a weekly look at COVID-19 activity now. And starting in October, that's going to be available for flu activity as well. So go to the next slide, please. So there's also, no real change in COVID-19 guidance from last spring. We got this, tried to get this message out a lot last year. COVID-19 should not be required to send someone home from a facility or to come into a facility. If someone is too sick to attend, they should be sent home. We get folks come to us a lot wanting to know about how long do you want us to keep kids out when they have COVID-19 or keep staff out when you have COVID-19. We're happy to have those conversations with you, but we do not have a blanket recommendation. General community settings, we'd say 5 days, but other factors can be considered around safe staffing and such. And then, for the general community recommendation is after those 5 days for someone who's been infected with COVID, when you're around others, to wear masks. Not everyone, particularly in this sector, can wear a mask due to age, due to other issues. We can, we encourage others to kind of help support these people by working on ventilation, really reinforcing hygiene, spacing to the extent that's possible, so that individuals can get back to participation after COVID-19 infection. Next slide, please. And again, it's the same, ventilation, spacing, and masking for those who can, as well as protective. If I'm going to be spending time around a kid who's recently been affected and I can wear a mask, I'm going to benefit from wearing that mask when I can. We also just really want, as facilities do with other illnesses, really look at the symptoms. If there's a fever, should be excluded. Sore throat, vomiting, diarrhea. If there's otherwise sort of no improvement in symptoms, an individual should probably continue to isolate from others with COVID-19. Next slide. Kind of alluded to, the sort of, I guess, the plus side of COVID existing along these other seasonal respiratory diseases, and it's really a lot of the same things that work apply. So it's reinforced. I know with some young kids, it's really hard to reinforce that covering coughs and sneeze. My kid was 4 going on 5 when the pandemic began, and he was such a good hand washer and sneezer. And he's really slacked, and I'm fully responsible for that. But anyway, hand washing too. Again, they sang the birthday song. It was great. Really work. We kind of need to continue to work on that. Cleaning surfaces at least once a day is going to be helpful. We started to hear a bit more about air quality during COVID-19. I'm really hoping that's something we continue to see advocated for and pushed for. But that's going to reduce the risk of airborne germs and other contaminants in our air. Again, staying home when sick, and now staying up to date on yearly vaccinations. We don't necessarily. There's some folks who are going to be recommended who may, recommendations may vary for some individuals, but for the most part, it's going to be, did you get your COVID shot this year? Please get your COVID shot this year. We're not going to have to do this complicated math about how many months it's been for many of us. So, and that's going to, so we'll go on to the next slide, please. We got some questions about reporting cases. Healthcare, childcare facilities, non K through 12 environments for kids are not required to report cases of COVID-19, of flu, of RSV, or other viral respiratory illness. But you can absolutely reach out to us if you are in need of support, if you want some guidance. If you have tested positive, or a staff member or a child has tested positive for COVID and you'd like guidance, you can reach out to your local health office. You can reach the COVID Epi program email. You can call the infectious disease Epi team. And on the next slide, we'll see we're going to have, starting in the fall, a little 1-page report form if there's a flu outbreak. And you want support, you want to report it. Again, you are not required to report to us, but we want to be we want to be your partner. We want to help. So do not hesitate to call, to submit online if we can be of value to you. And then next slide. So as folks have heard, there's currently no plans for broad-based distribution of COVID-19 tests to schools or childcare from the state. We're still kind of rolling some test supply out to municipalities via libraries, via food shelves. So there is still some test supply that's getting out there. We're not going to have a formal program of providing them to, for example, schools. So there's still tests out there, But, the guidance really remains the same. Stay home when you're sick, stay up to date on your vaccinations, practice good hand hygiene, wear a mask if you might be contagious around others if possible. And if not, let folks know, and, try to take other mitigation steps there. So I think that's all I've got. So thank you.
Thank you, John. That was great. Just to reiterate, because that was a lot of information and it's all great, is that you will have access to those slides. We'll send those out. Just noting, not a lot has actually changed around the COVID recommendations with childcare. So we're going to be able to face this fall and this winter kind of knowing nothing's really changed that dramatically. So that's kind of a relief from previous, the early part of the pandemic when things were changing so fast. So, and I'm going to turn it over to Meredith now.
Hi, so I'm Meredith Plumpton. I'm a nurse. I also work in the immunization program at the health department. And I wanted to talk really briefly about some exciting vaccine news. So I also have a slide deck, so I'm just going to wait for that. You can go to the next slide. So I'm sure as childcare providers, you are all aware of the required immunizations for childcare entry. Excuse me. I linked it on the screen just so you have quick access to it. You can go to the next slide. As Dr. Bell alluded to earlier, we have some exciting news about RSV. So the FDA has approved 3 different products for RSV. It's a little bit confusing in the way that it is going to roll out. So FDA approved the products for adults first, and then they approved the product for kiddos second, but I think they're going to try and roll out the infant product, which we'll talk about in just a minute, first, which is exciting for all of the people on the call today. So there are 2 products for adults. Both of the products, Arexvy and Abrysvo, are approved for adults 60 and older. And then late in August, FDA also approved one of those products for pregnant individuals to get in their 3rd trimester of pregnancy to be able to pass along some antibodies to their babies, which is really good news. You can go to the next slide. So this is the one that we are very, very excited about. This is a product that is approved for infants, and it is to help prevent RSV in babies during their first RSV season, and then children a little bit older in their second RSV season that have certain health conditions that would make them more at risk. So this is a product that would be given at birth for kiddos born in the fall and early winter, or to kiddos born outside of RSV season at the start of RSV season. So kind of like the flu shot and the COVID shot for respiratory virus season. You can go to the next slide. We do have an updated vaccine that will prevent a couple more strains of pneumococcal, which is exciting. That's what prevents pneumonia in kiddos. So we've had one in the past that prevented against 13 strains. Most recently, we had one that prevented against 15 strains. And now we have one that's approved for 20 different strains. So hopefully we'll see less and less of that illness. You can go to the next slide. So I wanted to talk just briefly about flu vaccine and some updates for this year. In general, everybody 6 months and older should get a flu vaccine every year. And it's a little bit interesting the way that they have to do this. So they have to look at what flu viruses are circulating in the southern hemisphere, because they get their winter before us. And then they kind of make a prediction of what sort of flu viruses we're going to see in the United States, and they make a flu vaccine based off of that. Some years they do really well. Some years they miss the mark on which viruses will be circulating in our communities. But even if it is not the same viruses that they have predicted, getting that flu shot every year does help lessen flu, and it does help lessen hospitalizations, and it helps lessen the severity of flu and the amount of time that you're sick. So everybody 6 months older should get it. Adults 65 and older get a special formulation. And then flu shots are recommended for pregnant people. You can go to the next slide. I'm not going to read all of this. There's a lot of words on this page. I just wanted you all to have this information. We get asked a lot when the most optimal time is to be vaccinated for flu. And CDC really wants people to be vaccinated in September and October. That's not to say that if you haven't received your flu shot and it's November or December or even beyond, it is certainly okay to get the flu shot that time. But it does take a little while for those antibodies to work in your system and for you to build up that immunity. You can go to the next slide. I don't know if you have any families in your child care whose kiddos have not previously been able to be vaccinated because they have an egg allergy. But CDC made a new recommendation this year that even people with egg allergies can get flu vaccine, which is exciting. So if you have that, I would just pass that along to your families and let them know to have a conversation with their kiddos doctor. You can go to the next slide. Lots of questions about the COVID vaccine. You can go to the next slide. I just wanted to talk about some things that have already been touched upon. Yes, there is an updated COVID vaccine coming for this fall. We are actually hearing that it might be approved next week. If anybody has received a COVID vaccine before this year, it will continue to provide some protection. But this new COVID vaccine is specifically formulated for the variants that are circulating now. And then the three manufacturers that will have the new formulations are Pfizer, Moderna, and Novavax. So the big three that we've been seeing all along. We do have some information that these three manufacturers are still looking at kiddos 6 months and older. And then if you've heard in the news, COVID vaccines are going to be commercialized, which is a weird way to say it, but over the past couple of years, the federal government has provided COVID vaccines and nobody's had to pay for them. Now it's going to be more like any other vaccine, and pharmacies, providers, anybody who gives the vaccine will have to purchase it, and then they can charge insurance to give COVID vaccine. There is a program. So if anybody is an adult and doesn't have insurance, or their insurance won't pay for COVID vaccines, there is a federal program where you can go to specific pharmacies and specific providers throughout Vermont and still get the vaccine at no cost to you. So we are waiting for those details to be released through CDC and the federal government. And as soon as they are, we're going to have ads through the through our social media. I'm sure Dr. Levine and the governor will talk about where to go and get your COVID vaccine. So that's all that I had. Thank you very much.
Thank you, Meredith. That was great. So much information again. And I just want to reiterate that as we're going through the questions, there's going to be some of these topics covered again. I think it'll probably be beneficial to hear it another time because, you know, both John and Meredith have so much great information, and so it's good to hear it again. I think so. I'm just going to run through the questions here that were pre-submitted, and then, like we said, if there's questions that come up in the chat, we'll answer those if we have time too, and if not, we'll answer them via email. So the first question is what return to school recommendations do you have for children under age 2 who are recovering from COVID since they can't mask for days 6 through 10? So I was thinking maybe John, our pediatricians, can step in and offer some insight.
Yeah, so let me start with the observation that we've all been through together. So prior to COVID, I think we all have talked that our respiratory protocols were a little squishy, and there was a lot of challenges as people who care for children with the pressure on parents to return to work. And so we find ourselves there again. You're not going to get any recommendations from the health department in this space. Do you feel that? I guess you lived that last spring as well. So the current way we think about it is that you need to consider that if a child can't mask, they could, but they're well after a few days of COVID, they could come back after 5 days. But if they're really not able to mask, we know the virus can continue to be spread in the second 5 days. So that would leave the kid out for 10. I don't really have that much else to say in this space. I'm curious if John or Becca wants to think that through. It's very hard as where you sit to not hand a protocol out and say, this is the recommendation of the health department. And if I think the biggest thing I wanted to say at the onset too is we learned so much from you about the difference between a child appearing well at 8 o'clock in the morning to a parent who's got some work stress, and then 2 hours later, energy drops, unable to participate in childcare and not themselves. And I'm going to say this 4 more times between now and 2 o'clock. This pressure that you have to bring kids in, and these anecdotes that are real, that pediatricians are saying, the kid's fine, take the kid back. The only solution I have for you in this space is to team up in your community with the help of your public health nurses to have conversations between you, home-based providers, centers, and the people who care for children in your community. Because until we understand each other's worlds, and I know you already have these partnerships, but I have to keep bringing it back to, they don't really understand childcare as well as I'd like everyone to. And also you as experts who see kids every day need to make sure the medical homes understand what we just said. The kid's sort of well at 8. I mean, most people do wake up feeling pretty good, and then they can't participate. So I really want this to be more of a dialogue. I'm going to let Becca and John weigh in on what to do. Let's do the specific example of a child under 2 who can't mask, who tests positive. 10 days is a long time to be out of care. And I think after 5 days, if they're well, no fever, and the respiratory symptoms are gone, that they should be back in childcare. John, Becca?
Yeah, I can weigh in a little bit. So I think I also do want to take like a step back and think about how things have evolved in this exact group of people, in terms of a few years ago, how we would say we'd say things like 6 feet and 3 feet and masking for this many days. And part of that was because at the beginning of the pandemic, this was a totally novel virus to all of us, right? So there were no vaccines and no infection-induced immunity. And so scientists had an epidemiologist had a sense of transmission dynamics. And what do I mean by that? Do you remember, like, early in the pandemic, they would have like classrooms, they would have like a report, and it'd be like a classroom chart, and they'd be like, a COVID positive person was here, and then they could like map out who got COVID, right? Like everyone was vulnerable, everyone was immune naive, meaning and we could tell, like, okay, 3 feet makes this much difference, 6 feet makes this much difference, a mask makes this much difference. You could really kind of like clarify that. So now we're at this point where everyone has been vaccinated, hopefully, or in many cases both, have had the virus. And we've all had it at different stages, and our immune systems have all have all seen this. The exception is some of the kids you care for who are young, who may not have had it yet or may not be vaccinated. But generally what I mean by that is like, it's a little harder for us to say like how this spreads and the transmission dynamics, because we are all very different. Our immune systems are really different. And the reason why I'm just bringing this up is that it's not so simple anymore to say like, okay, like if we are all 3 feet apart, we're going to reduce transmission by like this percentage. Like that just doesn't exist anymore. And COVID is really just much more like the way we think about all the other respiratory viruses. And so when you ask such really good questions, and then we say like, you know, kind of like we do the best we can, or there are recommendations but not requirements, it's sort of because of this, because it's really hard to quantify, you know, what the effect of, say, you know, the masking might be. So, you know, again, we're really saying that children, when they're well, should come back to school, come back to childcare, come back to school. We should be going back to work when we're feeling well, and we can participate in work and school and care. And so, if the child's well, they can come back. Remember, they don't have to have a COVID test. And so we don't know if the child's symptoms are due to COVID or RSV or influenza or parainfluenza or rhinovirus or adenovirus or metapneumovirus, which we're going to see all fall. Like there's like a million viruses and the kids are going to get all of them. And so thinking about like what is and this is true for all these questions, like the main time where people can transmit viruses is right at the beginning, when they've got fevers, when they're feeling unwell. And so that's why we say, okay, if you have fevers, you're home. If you're unwell, you're home. And we'll talk about this a little bit more, but these kids get like continued like runny nose, right? They get that cough that kind of lingers. They're much less infectious at that point with whatever it is, whether it's RSV, whether it's COVID, whether it's something else. So, so really just thinking about, I think about COVID really in terms of like our patients, our pediatric patients. It's really very similar to like, especially in this age group, a lot of other viruses. So just hand washing, you know, when you're really unwell and not able to participate, you're home. Otherwise, you know, they should be able to come back to school. And I think when one of these sessions, maybe last year, I like showed those graphs where they did these studies where they like swabbed kids' noses like every week, and there's like a virus in their nose every week. And then when they were swabbing adults, you know, if they lived in houses with kids, they also had that. So we wanna have, knowing that they're gonna have like multiple viruses over this fall and winter, how do we keep them home during like the time where they're most likely to transmit? And those are those few early days when they've got fevers and they aren't feeling well. And I've just been thinking so much about how you all are caring for kids. I mean, as pediatricians, we're like, this is the most important time for kids, right? Like these years are the most important times for kids developmentally. So if you think about like you all are seeing them when they're like taking their first steps and they're saying their first words, and also when they're getting all their first colds, because this is the time their immune system is learning and they're getting exposed to all these viruses. And so that is a real challenge with working with this age group, is that they get every single virus and they get it for the first time, usually while you're caring for them, and that's challenging. So that's kind of the theme for probably a lot of our answers for these questions.
Well, and I can jump ahead to a specific question. I really loved everything Becca said. If you do have a child under 2 who tests positive for COVID, which of course later there's a question about this still only way to diagnose COVID in a child under 2 is with a PCR. You know, remember that test problem, that the antigen test that we now all have and use for our own care are not approved under 2. So if you actually do have a child who has COVID confirmed by PCR, the people that are exposed to them is not really a thing anymore. That's another like marching across our cognitive. There's no close contact. I mean, they do have some recommendations at the CDC that if someone's a close contact, there's a certain way to proceed and watch for symptoms and when to test, but that there's no tracking down anymore. There's no contact tracing. And I think what Becca's trying to make the case about is that we're going to have so many respiratory viruses, and that the trying to say where a kid got COVID is not really a thing anymore. And that's really important to me. We just went through this in my extended family, and our brains still want to know where people get COVID. And it's not really fair because it's everywhere. And I felt that acutely, personally, recently with a couple of family members, like the Bruce Springsteen concert. I don't know. I don't want to blame it on Bruce Springsteen. So I wonder about that piece for you, because some of you have asked about communication with families and when staff members test positive and or children. I think you're going to have a lot of cases of kids with respiratory disease that aren't testing. So I wanted to start there, and you're just going to have to sort of wonder if they have COVID, but if they're well and they don't have fever and they come back, you don't have to do anything about that. It doesn't really matter if they had COVID. I think you're going to have people who call you and say, my son has COVID. And then you're going to have staff who say, I have COVID, or don't feel well, don't test. I also just experienced that in my personal life where this family, extended friends said they had a cold and they weren't testing because they knew it wasn't COVID. I'm like, how is that possible? Right. So the messy space you find yourselves is going to give you every iteration of the opportunity to be infectious disease experts and say, if kids have active symptoms of mostly fever and they're not acting like themselves, they shouldn't be here, nor should staff. But when people come back with or without a test, there is no guideline for you. That's what we're trying to really scaffold you and support you in the idea that you don't have to keep your staff person out 10 days when they test positive. They can come back when they're feeling well. I mean, the protocol is for adults to mask, isolate for 5 days, and then mask for 5. So I'm wondering how this is going to play out. And I don't think we're going to be able to answer every scenario today, but we're a resource to you all for this type of cases. I think in particular through Katie, if you just pop scenarios to Katie, we can just, that you're not gonna be able to get official state government advice, but you can start to get the sort of pediatric sense of how we're functioning in communities in the weeks and months ahead, with the recognition there's tons of respiratory viruses. So John or Becca, anything else? I know that lands pretty squishy.
No, I think you both provided really a lot of helpful kind of context. I mean, before COVID, we have, Brina, you touched on this kind of urge to know when you got it from, or even what it is. There wasn't this necessarily urge to know, was this a rhinovirus? Was this a coronavirus? And, yeah, we have, particularly, I know there are a lot of frankly bad faith and dishonest people very early in the pandemic who were saying it's just a cold, it's just a flu. So I don't want to, I understand that language can be hard to hear as we kind of move us toward thinking of COVID as a disease that exists alongside these other similar diseases. In practice, that's what it is. I think we've kind of alluded to, if we had a 10-day, you got to be out 10 days to get, come back with COVID, ain't nobody COVID testing at that point, if that's the rule. We want, it's helpful to know, we want to be kind of, we want to be good partners to you guys and provide help where we can. But like Brina's saying, we're not going to be able to give you, direction. We don't on, X number of days, X number of feet. We want to be a resource, but we're not in an emergency state anymore. So we're a partner, but we can't tell you exactly what to do. But we're happy to hear about specific situations, and if they come up here, we're happy to talk through.
Well, I am looking at the time, which is 1:45, and we are in question 1, so which is fine. I think this is good because I think what Brina and Becca and John just did was sort of answer a lot of the questions. We're all very similar around the COVID pieces, around who should stay out how long and who should get tested and who should. So it feels like we're sort of globally answering these questions. And John and Meredith and Brina and Becca did that also in their presentations and their talks around sort of a lot of these questions. I think I might just jump ahead There is one question, well, Brina actually answered the testing question too around for children under age 2. It's still just a PCR test that's recommended or that they're approved for, I should say. And I'm going to skip ahead because we did talk about the vaccines. We did talk about the COVID pieces, but there were some questions that were not COVID, which is exciting. So I wanted to just give those a little bit of airtime as well, if everyone feels like it's okay to jump ahead.
Definitely.
Okay. All right. Can you explain why some docs might allow a child to return to school with viral pink eye, not treated, versus bacterial?
Yeah, well, I'd rather talk about viral conjunctivitis than talk about why a pediatric colleague would do a certain behavior. I think somehow in the history of caring for children, we became very frightened of the oozy eye, and the large percentage of eye drainage is just the extension of the fact the eye is connected to the nose, and that it's just the reaction to the virus that causes inflammation and mucus to come out of the eyes. So these protocols that you have to be on drops to come back, or that you have to be tested or somehow understand if it's bacterial or viral, kind of got out ahead of the actual science here, which is that the vast majority of the discharge is just the cold. So same protocol for if you have a cold. If the kid is not well and has fever and there's active drainage of eyes and nose, they should stay out. But if they're back to their normal selves and they occasionally need a wipe with some hand washing, it's fine to be in care. Bacterial conjunctivitis is a different entity. You often don't have the respiratory component, you have a drippy, angry looking eye. Sometimes both eyes, more likely just one, and that needs medical attention and drops, sometimes oral antibiotic. So really not up to you to sort out, but once, I don't know what the exact scenario is, but if the child's been seen in a medical setting and the decision is it's not of concern, that relates to the fact that it's a recovering cold that's oozing out the eye. I hope that's helpful. Again, completely messy because so many of us, I have a lot of experience in school nursing, and there's all these protocols that the minute the eye turns red, you got to go straight home, which actually doesn't reflect science.
Thank you. I'm going to go there. Hand, foot, and mouth here. So when should infants and toddlers return to care after hand, foot, and mouth? A child may be fever-free but has fluid-filled blisters. We're told they can return, but we can't stop that spread in the center. So any kind of advice around that?
Well, first of all, I love hand, foot, and mouth questions because it's a sign of like a hot summer, although I don't like climate change. So the hand, foot, and mouth is one of what we call the enteroviruses. The word entero in Latin means intestine. And someone had asked an earlier question, is there an uptick in GI illnesses in the state of Vermont right now? I don't know the epidemiology on that. I just know that in August and September in pediatric practice, everyone has hand, foot, and mouth, and everyone has some form of diarrhea. So those types of viruses cluster together. So when you hear kids have a little bit more GI stuff, you also see an uptick in hand, foot, and mouth. The hallmark of hand, foot, and mouth is fever that precedes the eruption of the blisters, and the contagion of the virus is when they're sick and have the fever. So it's almost impossible to get out ahead of it. And it's another example of something where I really feel for you, because you exclude kids when they have fever, but they develop the fever under your watch, right? They come in the morning, they're okay. They have a high fever in the afternoon, they go home, but the virus is in your center or your home. So the way to get out ahead of it is nothing about the blisters or excluding kids who still have active lesions. It's about your general infectious disease protocols about the spread of virus, hand washing, wiping down your surfaces once a day, and just knowing that sometimes many kids get the same virus in the same couple of days. I feel for you on this one, because I love that Becca brought up the studies about where does COVID go, the studies about where Coxsackie virus is when they come out, that's the hand, foot, and mouth, when it comes out of your mouth, it's, you can be far away and contract it. Just like measles. I mean, we have so many infectious diseases that spread like wildfire, and this Coxsackie is one of them. So kids with fever should stay home. Basic principle. But please don't exclude kids that are perfect and well and running around laughing, but just have a few of those residual blisters.
There's a question I'm going to sort of summarize around just the common cold and what to tell families around the common cold, and symptoms like coughing and mucus, and when to exclude, and when, because those are all signs of virus, and it feels really complicated to try to figure out like where they are in that recovery space. And we've talked about this in previous calls, and I know Becca's had some really nice sort of language around talking with families and interacting with pediatricians around when they can return with symptoms of the virus.
Yeah, I feel like we've talked about this a bunch today, but it's I guess the urban legend, the myths here are that the color of the mucus portends a different duration of illness, whether or not it's a virus or a bacteria or anything about the severity. It's actually kind of a fascinating science, like what happens up in our nasal passage in reaction to a cold or virus, and how our body, depending on its anatomy and how shaped it all comes, whether it turns green. Such an interesting part of medical education that no one ever talks about. However, we're back to that concept again, that you're an expert in these kids every day, and you can see when they're not well and they can't be in care because they lie down at 10 o'clock in the morning, or they go grab their blanket and they're over in the corner and they're not playing. So with or without respiratory symptoms, like that's a kid that needs attention and needs to go home or be not in care. So that's the art of what you do. So it's not the color of the mucus, it's the kid around the mucus. But the other part you've taught me, and remember, these partnerships are what matter. You know so much about this, and if the pediatricians and family docs in your community are coming in with a different, I got to get you guys together and we're happy to help to have these conversations. It's just understanding each other's roles and professionalism. But I do wonder sometimes if wiping is a staffing issue, and then you have to say, I can't do this today. I know this kid's smiling and laughing and telling jokes and doesn't have a fever, but we can't keep up with the drainage. So that's the partnership you already have with families, to say, I know you need him here and he's doing pretty well in terms of his energy, but this is really significant. So it's not like it all goes binary. It's like this whole milieu of how the day flows and what you are experts in, which is the care of the group, small, medium, and large. I mean, some of you have just a couple kids, some of you have tons of kids. How does the day look when there's one kid that's just... So I'm very interested in you reaching out to us for partnering, so that we stop hearing that pediatricians are writing notes saying, go back, it's fine. Because it's just understanding each other, relationships, and partnering. That's my little utopia.
And we have just a few
Katie,
minutes
if it's
left.
okay.
Oh yeah. Yep, go ahead.
I might just because we have a few minutes left, I might kind of like summarize some action items, if that sounds great. So I think, in reviewing all the questions we got from you all, you are both very, so focused and concerned about children's health, which is so important. And then, but also like staff health for many reasons, including just your own health. So you care about that, obviously, but then also you need to keep the places open and you want to be able to care for kids. So maybe we could, and people can add if I forget anything, but let's talk first about staff health heading in. It is so hot outside, but fall is coming, winter is coming, it's coming. This respiratory viral season is coming. So how do we keep staff healthy? So flu shot, I usually just say like October is flu shot month, like get your flu shot in October. So letting your staff know flu shot in October is something you need to just get every single year. It's different every year. So flu shot this October. if you have staff that are over 60, they can and should get the RSV vaccine. So there's an RSV vaccine for those over 60. You know, if anyone over 60 who's working in a childcare center is going to be exposed to RSV starting in like a couple months. So go ahead and get that RSV vaccine. And then I'm sorry we're doing this before the ACIP meeting next week. We don't really know what the COVID boosters, exactly who it's going to be recommended for, but just keep your eye out. And when you hear next week who is recommended to get the vaccine, the updated booster, let your staff know. So those 3 for staff: flu, RSV if you're over 60, and then keep your eye out for the COVID booster. And then for the children, same thing, flu vaccine, they can start getting it now, like September, October, great time. Anyone over 6 months, any child over 6 months needs to get the flu vaccine. I'm looking at like the folks on this call. I think Katie, Meredith, Brina, and I, through Luann, will try to get you information about the RSV shot for children when we've got, like, basically when it's available for families to get, right? So we want to be able to provide you all with information that you can give to families when we know it's in offices or we know it's available and people can get. That's not yet, but there is this RSV shot. This is the monoclonal antibody that the young children can get. So that's coming. That would be a recommendation, but we don't have that information yet. And then again, keeping an eye out for the COVID booster recommendations. We do want children vaccinated for COVID. So you are dealing with a population that's new to, just born. And so when they become eligible to get their first COVID shot, we're recommending that they get that. So those 3 things. And then knowing that in preparation, we start to see rhinovirus really pick up usually in September. So we're going to start seeing that soon, I'm suspecting. John mentioned RSV, we're seeing in southeastern US. I suspect we're going to start seeing it up here probably by October, November, which is sort of like last year. Usually the RSV season is really bad for 12 weeks every single year. Every single year it's bad for 12 weeks. It's usually January, February, March. Last year it was October, November, December. So it'll probably be something like that here again, like November, December, January. So just be prepared for that. So that's kind of my summary. If anyone else has any sort of like action items to take away from this, just so you feel like empowered with some new information.
I do want to put one more plug in, which is, again, like what Brina was saying with the teaming. I mean, we've got some good resources. John's team, you can call them at the Department of Health. You also have a nurse in your region, in every region that works for the Department of Health, a nurse dedicated to family and child health, who is also tasked with answering questions from child cares. So you have a resource who's in your region, and it's really important to reach out to them and to elevate some of these concerns or problems or any kind of issues you're seeing in your community with your pediatricians, all these kinds of things, because that's how we know what's going on. So you can reach out to your family and child health nurse coordinator, which I'll send out a list of after this, and they can gather what they're hearing from their community and elevate it up to us so that we can help if there's specific situations and things like that. So you do have a lot of support right in your own regions.
And as always, this is so much important information. And I, from my perspective, watching this and comparing this to years past, we are so fortunate to have all of you gather for this conversation and to have the medical experts here to help us navigate through this. And the one thing that the last plug I would put in is that so much of this is about relationships with families and ongoing communication with your families. One of the changes that's happened over time is during COVID is that parents are used to talking about illnesses and excluding children. So it's a little bit, I think, easier to talk about why and when children might be excluded. So we know it's hard. We know you are on the front lines doing amazing work, and we appreciate you all doing this. And we will be back next season with more. I continue to reach out in the meantime through all these links that you're going to be receiving after this. And we thank you for taking the time. Have a good afternoon, everybody.